Wash your hands with soap for at least 20 seconds and wear a mask. Such reminders have become ubiquitous since the start of the COVID-19 pandemic. Hospitals are supposed to be the flag bearers of hygienic practices to curb the spread of infectious diseases. Today, we'll ask if public hospitals in India are hygienic. I'm your host Abhishek, and this week on Research Radio, we'll speak to Payal Hathi and Nikhil Srivastav about how caste-based discrimination by Savarnas negatively affects the health of patients and leads to exploitative work conditions for hospital cleaners. Payal Hathi is with the Research Institute for Compassionate Economics, RICE, and is a graduate student at the University of California, Berkeley in the US. Nikhil Srivastav is also with RICE and Research and Action for Health in India, RAHI. I've shared a link to the article we'll be discussing in the description of this podcast. And just a disclaimer, this research was conducted before the pandemic started. Thanks so much for joining us, Nikhil and Payal. I'm looking forward to our conversation.
Thank you, Abhishek, for having us.
Thank you. Thank you for having us.
So, could you start by taking us to one of the hospitals that you focused on, and perhaps how areas were divided, what the crowd size was like, and more?
Every facility we visited was pretty different. I think in terms of crowd size, definitely the larger district hospitals were very crowded and the smaller PHCs were not crowded at all. I think, though, that the main thing that we noticed across all of these facilities was this, this real emphasis on making sure that the facility looks clean. But looking a little bit deeper, spending time with the cleaners and talking just with different levels of staff people, it became very clear that this kind of surface level cleaning is not the same thing as better care for patients because of the way that the work of patient care is being done. When we arrived, there's a district hospital in Uttar Pradesh that we went to. We were not allowed inside one of the wards, the kind of general ward, which was sort of out of the ordinary. We were told that a government official was there from outside. And then we went to the maternity ward and saw the same thing with many families sort of just sitting outside on the ground and the doors closed. And we learned that these were all attendants of patients who had been kicked out of the ward because cleaning was happening inside. And so among those attendants, there were several newborn babies who had already been separated from their mothers for several hours. And then when we were finally let in, the ward was incredibly clean and, smelling fresh and all that. But some of the mothers were kind of complaining about how hungry they were. I don't know, it was just in this instance, for the sake of this visiting official, cleanliness seemed to be such a priority that it came even at the expense of mothers and babies who had come to the hospital for care. There's this awareness of what a clean facility is supposed to look like, but the behaviors, the practices, professional cooperation, these things are sort of difficult to observe.
Like every facility or even outside the hospitals, every institution has a schedule, and so do public hospitals in North India. But when you go there early in the morning, the place is really filthy. And then around 10 o'clock, when the in-charge is going to come on round, all of the cleaning is happening right before that. And then all of the patients' attendants get kicked outside the ward so that this in-charge can see that there is nobody inside the rooms. But as soon as the round ends, this person's round ends, the facility starts to degrade over time very quickly. And by the evening, the whole facilities, or most of these facilities, look filled up with trash, and all of the attendants are inside the rooms, and having two patients on the bed and one on the ground is a very common sight in these overcrowded public hospitals. And all of these patients with maybe two or three of the attendants makes these facilities very, very, very crowded and very difficult to for infection control. And it's also the lack of resources which is playing out in there.
And there was an instance where after one of your interviews, authorities cleaned the hospital in a matter of hours. Can you tell me more about this and maybe other ways that your presence as researchers impacted caste-based hierarchies and hygiene in the hospital?
This was one of the first hospitals, actually, that we had visited. It was quite early on a Sunday morning, and we, I guess, made the mistake of starting to ask right away questions about the trash pile. There was a large trash pile outside of one of the wards. It was, I think, the general ward, because it was quite shocking to see so much hospital waste, including, needles and IV bags and kind of bloodied cloth and all these things just kind of lying on the ground. People were throwing their food on the ground. There was an elderly man sort of kind of eating his food very close to that. There were toilets very close to that also, and feces on the ground. And then we walked into the ward, and it was incredibly packed, and it was quite difficult to walk through. We were trying to get to the nurses station to talk with them and notice sort of that there was like not very much gloves weren't being used. There was a doctor there who said, you guys are going to catch something, you shouldn't be here. And so anyway, so we went back that evening, and the trash was certainly all gone. We went back the next day, and it was clear that like there was this massive cleaning effort underway. Machines sort of mopping the floor. The day before, we had been able to speak with some of the cleaners, some of the staff, but the second day when we got back, when the cleaning was happening, just to try to understand, like, is this a normal process? Like maybe this happens every week, but people were not comfortable talking with us anymore at that point. So, certainly I think we had made people uncomfortable by asking these questions. And at another hospital in Bihar, we were talking with a delivery room cleaner, and about 5 minutes into the interview, a man kind of interrupted and started hovering near us. And so we're trying to ask him, like, hey, can we speak with her and finish our conversation? And he said, why are you speaking with her? Why don't you speak with one of the staff so you'll actually understand something? And so she said, they're speaking to me about cleaning. And he kind of asked us, like, do you know what post that she's in? And she said, yes, they know that I'm a sweeper. And again, he sort of told us, go speak with a staff person, and that it's for our own good that he's telling us. It was incredibly demeaning to this woman. And then a couple of minutes later, she was asked by one of the nurses to stop talking to us and come back, even though we had gotten permission to speak with her.
It was like sort of surprising to see that people's behavior did change when we were around, like these urban people coming from the cities. Those are like not a common scene in like public hospital ward. The sort of patients that are seen there are coming from a relatively weaker background, economic background, and so people could tell that these outsiders are here and they are seeing things, so they don't know. So their behavior did change in terms of hygiene. So the hospital did get clean in the evening when we went there, and on the second day, as Payal said, that there was a massive cleaning drive going on in the hospital. But something that was really, really surprising was that people's behavior in terms of interacting with the cleaners, the caste hierarchies and the hierarchy within the hospitals, those behaviors didn't really change, which tells a lot about how internalized these things are. And people don't even see that they shouldn't be doing this in front of outsiders or people who are coming into the hospital. So it did like reflect onto us and like told us that look, like what are the priorities of the staff in the hospitals.
Right. Could you elaborate on how understandings of dirt, purity, and pollution among hospital staff affect efforts by hospital authorities to keep patients, cleaners, and other hospital members safe and healthy? In other words, what is missed when hygiene is framed as a solely logistical problem?
Yeah, so this reminds me of this really nice person we met in one of the district hospitals in MP. He's the head pathologist, like I mean the microbiologist in the hospital, and it is his job to be doing infection control for the hospital. It was like really early in the morning, 8ish. We had showed up in the hospital, and he was the first one to be present there. So it clearly shows that he was very dedicated and towards his job. But while we were sitting with him, he pulled out this stash of slides and started treating them with heat, like by putting fire below it. When we asked him like, what are you doing? He said these are like TB samples, and I'm testing if these samples are TB positive or not. All the time, to our surprise, he was not wearing gloves. And in a few minutes after he was done with this, he tossed the previous day's slide outside the window. Later in the conversation, when we asked him, are you not scared about catching infection and you don't wear gloves? And his response was like, bindas rehna chahiye. If see me, I've been working here for 35 years, and if I worry too much, I think I'll catch something. But if I leave things up to the God, I will be fine. And see me, I have been fine for so long, 35 years of my job. This clearly shows how people overlook the germ theory of disease. And this is the person whose whole training has been on the germ theory of disease. And he is the person in the hospital responsible for infection control. Although he's a really nice person, a very soft spoken person, a really, really dedicated person for his job, and that was the reason why he showed up really early in the morning to the hospital. But when it comes to adherence to the germ theory of disease, he, for some reason, is not taking it seriously and putting his life and the life of other people at risk.
This relationship between just casteism and patient safety, it became clear once we started talking to the cleaners. There's of course these supply issues that sort of prevent cleaners from doing their jobs properly, and even protective gears for them, for their own selves, that kind of prevent them from spreading anything. But the second problem, I don't know, is in the article we call it this task shifting thing. Cleaners are sort of always asked to do tasks that are meant to be done by other staff members. So we saw cleaners putting in catheters, changing IV bottles. One cleaner we met, she told us that she delivers babies pretty regularly. And their sort of low position in the social hierarchy means that they find it difficult to say no when they're asked to do these things. So, not only are untrained staff members caring for patients, but it's also that their own cleaning work then kind of doesn't happen as it needs to. And, these casteist notions of purity and pollution mean that like nobody is going to actually do the work that the cleaner has to do. And they are, even though they are constantly being asked to do other work. And so, the cleaning work sort of gets left behind. I think another kind of telling case was another man that we met in Uttar Pradesh. He was a retired cleaner, actually, who was working. We met him in the burn unit, actually, like without gloves, dressing people's wounds, kind of cleaning the floor with this kind of blackish water. But, as we were talking to him, we learned that he is responsible, and, that the reason that he had been called back is because there was nobody to come and take care of the patients who are like homeless and that have no one to take care of them. And so he took us to the room where these patients were staying. And, it was, there's urine and feces all over the floor. Like one man had almost no clothes on. A woman was sleeping with no mattress on one of the beds, and I think it's clear, like, he's being asked to work with these particular patients because, there's just a lot of human fluids, and like these are the jobs that are passed on to cleaners because these casteist beliefs sort of prevent people of higher caste from even being willing to do that type of work. So I think framing hygiene as just a logistical problem is, missing these relational dynamics that create a situation that even if we had all the supplies in the world, cleaning sometimes isn't going to happen with these kinds of dynamics, these casteist responsibility breakdowns. That's neither good for the cleaners or staff or patients.
Yes. And you write that, quote, a doctor in Madhya Pradesh explained that if he could not find a cleaner, the dirtiness will stay, end quote. Can you expand on the caste hierarchy within hospitals and the role that the family unit plays in restricting social and labor mobility?
There's this attitude that we found everywhere, this like sabka kaam alag hai, that we can't do anyone else's work, although this really in reality only really applies to the work of a cleaner. Many people told us that, like, if there's no cleaner available, they'll simply keep that dirtiness there. They'll just wait till the cleaner can be found. So in smaller facilities, this sometimes meant even waiting overnight. At bigger places, people also mentioned to us that since cleaners sort of live with other individuals of the same caste, within their family or their community, they would just go and find a cleaner, which sort of means anyone of the same caste. It's this understanding of cleaners as sort of interchangeable among their caste. Also this belief that no training is needed for these people, that just by being a person of that caste, you can and should be able to do this cleaning work. I don't know, one of the most hard-hitting quotes that we heard from this cleaner in Bihar, he sort of said, what training do we have? We were asking him about the training that they receive, and he said, we don't receive training. Like our people are of low caste, and from childhood, this is our training. Sort of, we've been doing this since we were young, and so like what other training is there?
Yeah, I feel like his quote tells us a lot, and like he's echoing what his higher officials have been like treating him with. So in the officials as well, like there aren't very many trainings for cleaners, and like you need special training to be able to do infection control in the hospital. But because they are seen as like as this is their job and this is what they have been doing since their childhood, they are they have like good enough resources and knowledge of to be able to control infections. And it also shows like how maybe like I'm jumping ahead of myself, but just to mention it like in short in a bit here, that like most of the focus in hospital hygiene is on visible cleanliness and not infection control. So if the goal is to achieve visible cleanliness, these people have been doing it for a very long time since their childhood. that's enough. But if we want to reduce infections in hospitals and save lives, then they should be given some training, and which isn't the case.
Right, right. And something that I found quite interesting in the article is how you mentioned that hospital cleaners often denied that discrimination was even taking place despite everything that you've shared so far. Even so, nurses and doctors expected that all the cleaning and sorting of and segregation of medical waste would be done by the cleaners. How did how did cleaners perceive this?
Yeah, there, I remember there's a cleaner in UP. He started saying, no, there's no discrimination, but then like immediately went on to talk to us about how, he won't sit down with other staff, and definitely not on a chair, like maybe on a stool, if at all. And that like by sitting on the same level, it would cause other people to feel bad once they found out what his caste was. So there's definitely this like internalization of the rules of the system that are kind of just followed because that's the way that things are done. I think without recognizing that these are rules that are sort of meant to be oppressive. I don't know. And many cleaners talked about their fears of infection for sure, that they're worried about their families when they go home from doing work like this, but also just this kind of hopelessness. There isn't anybody to talk to or ask or do anything. No one is going to do anything about this. Many of them talked about how it's very difficult to even think about getting any other kind of a job. This is the only thing they've ever done. They're not educated. But, like many were also expressing the sentiment that they don't want their kids to be doing the same work. But overall, also just trying to just do a good job for the patients who they feel they're working to take care of also.
I remember two instances which like explain this part quite well. Maybe one was this person who is a cleaner in a small PHC. He remembered his first day when he went to get his job. This friend of him or a relative of him took him to the Bada Sahab, where he just squatted on the ground, and this must have been like around in the early 80s or late 80s or something. Like he's an old man now. He was saying that like that day I was told by this person who has introduced me to the Bada Sahab and has got me this place to work. He told me that never forget what your place is. Never sit at the same level as the other staff do. So always either sit on the ground or have a dedicated stool where no one else sits on. And when we go to the public hospitals or like other public offices, like what people call them fourth class employees, which is a demeaning thing. And now I think the government has taken a step to change that name by saying like all purpose employees or something like that. So they have a separate place to be sitting in. So this shows like how it has been internalized by the oppressed. And then the other instance which I recall is from another big CHC in Bihar, where a head nurse who was a young lady in her early 20s told us that when we asked her if like people when they are doing lunch, do they eat together or not, and she said yeah, we all come together and eat. And then we prompted if cleaners also come together and eat with them, and she said no, you know what their caste is, and they know their place, they won't come inside, and even if we call them they won't come inside. So there is this like knowledge and internalization of the caste hierarchical rules, both accepted by the oppressed and the oppressor. On the surface, they would say that no, we can all mingle, but neither would want to break those rules. And if the oppressed breaks those rules, there are clear ramifications of being kicked out by out of the job, and all of these other issues that one could face.
Right, right. I was also trying to understand if some of the behaviors and actions by doctors and nurses might have played a role in the level of uncleanliness that cleaners had to deal with. Because you've written in the article where there was an assumption that cleaners would always clean, and there was this nurse who did not even bother to segregate waste. This would then fall on cleaners who would have to go through this waste with their bare hands or with very limited safety equipment. Could you elaborate on this practice by doctors and nurses and how that impacted the level of cleanliness in hospitals?
Yeah, so the actions of the doctors and nurses, they clearly show the caste hierarchies. And like as we have written in the article, and you mentioned that the waste, like, so when you step in the hospitals nowadays, there is this like poster which shows black bin, blue bin, red bin, yellow bin. Black bin is for general waste, yellow bin is for biohazard waste, and blue bin is perhaps for plastic waste. And then that's like waste segregation is happening, and like we are working towards a clean environment and also protecting everyone's lives. But in practice, all this is not happening. Like, although there are all of these bins present in the hospital, but on a regular day-to-day basis, everything goes in them, like including the needles, the empty injection vials, or the IV bottles and the pipes. So, and the body fluids and like swabs and everything would go in every bin. It will not get segregated. Then it's expected that somebody, either the cleaner in the hospital, would segregate it, or someone else at the biohazard plant, bio-waste plant would segregate it. So sometimes what ends up happening is that, because sometimes you can sell the IV bottles to the kabadiwala for a good price, some cleaners would end up like picking them up and then selling them to the kabadiwala, making some money out of it. Sometimes it would like go straight to the bio-waste plant. We also visited a bio-waste plant where the plant operator, the manager, was getting some really like poor people who again were of which is seen to be the cleaning community, asking them to segregate the needles and then the IV bottles in order to like sell it to the kabadiwala to make some money off of it. So this is like one behavior which shows like the clear hierarchies.
Yeah, the thing that I was thinking of was not so much from nurses and doctors, but from other just people in the hospital. Many of the cleaners that we spoke to talked about how, people treat it as if it's just some outside space that's not their own home. Like, even though they're going to be here for several days, they will just throw the trash on the floor, and rather than trying to take care of the space they're in for their own patient, for the other patients, they know that we're there to clean it up, and so they'll just throw the trash out the window or leave their food on the floor. Or, and I remember one woman told us how she had tried to ask some of the families that, like, please, can you just take it and throw it in that garbage can over there. And they got very upset at her that, like, who are you to ask us this? And, we'll behave as we want to behave. Like, you shouldn't even be able to ask us this. And so that type of, like, I don't know, just kind of dismissiveness of this person as like, who cares about what your work is? Like, we can behave as we want, and you just do the work.
And then like also this fact of no training for cleaners. And when you ask somebody that can you not teach them how to make sure that infection control is happening, the response would be they are not educated, they cannot understand things, and that's why like this is how things go. Like, that very fact clearly shows what the place cleaners have in this whole hierarchical system.
On this infection control point, I think we also learned that in many of these facilities, it's not the cleaners who go for the infection control cleaning. It's like, I remember in one facility, it was like the lab manager who went, and then it was his responsibility to communicate that to the cleaners, rather than just training the cleaners directly, since they would be the ones in charge of this. Exactly what Nikhil is saying. They were not seen as being able to understand. And so, like, don't waste the training on them. Train someone who will understand, and then hopefully it will sort of trickle down to them.
And then the lab technician would say that I cannot teach them because they are uneducated and they don't understand, which isn't true. Like, poor people, uneducated people, it's not that they cannot understand. It's like you have to put a little more effort. And if we see the behavior of the health staff, the higher up, the really educated ones, I remember a doctor, one of the pediatrician, we walked into his room and he said, asked him like, do you not wear mask or gloves when you are in the OPD? And he said, I can tell when somebody is walking in the room if the person has infection or not. That's, if the argument of not being able to understand the germ theory of disease, it applies to the really well-educated people as well. So we should be seeing cleaners and everyone as human beings and as people who have brains and can understand. And we have to like have the language that is easy to understand and like reinforce it again and again. And that's the whole job of the hospital administration.
Right, right. And one of your interlocutors, a cleaner, said that, quote, there is no one who is willing to speak. You must understand. If I speak up, then they would think I'm being an activist, and I would be the first to go, to be fired. Out of fear, no one speaks, end quote. Could you expand on issues of precarious employment and contractual labor, and maybe how all these goals of of making delivery safer, enabling cleaners with already enshrined labor rights, and removing caste-based occupational restrictions be achieved? How can these goals be combined?
Yeah, I mean, this definitely was a big issue. We saw, more and more cleaning jobs are being outsourced to these private contractors, which is problematic for a lot of reasons. They pay less, there's lots of delayed payments, again, no training at all. And it sort of creates this two-tiered system of cleaners because there are some cleaners who are there who are government employees, and then there's these newer employees who are contract employees. And so, it's different per state, like which of the problems are most important. Like I think in MP, many of the cleaning jobs had been cut, but lots of payment delays for the people who were there. I think in Bihar, we noticed that there were inconsistent wages, even between cleaners in the same hospital. In UP, we found a facility that had no cleaners at all. And so the DAIs were sort of doing the cleaning work with no pay. And then another facility where a cleaner, I think just in the few days before, had been told that you're not going to be paid for the past month of your work. And if you want to stay, you can stay or you can leave. Like just kind of casting them out as, well, sorry, there's nothing we can do about this. And so, and the differences between contract workers and government workers is also pretty stark. Like the amount of money the contract workers, I think we found between 1,500 and 7,000 or so per month, like paid daily. So, if they get sick or something, obviously they don't get paid. There's no job security, whereas government employees are receiving 20,000, 25,000 a month with job security. So, some people, I think, told us that this is a better system, this contract system, because it really gets cleaners to show up and do the work. But then there's also this animosity, obviously, between government and contract cleaners. And that obviously negatively, it has an impact on the work. And I think many of these cleaners, the contract cleaners, are like sort of staying in the job for this promise of like, maybe if I stay long enough, if I do a little bit more, I will get this permanent job. But given this general trend of moving towards these contractual kind of things, it doesn't seem very promising. But that cleaner that you quoted, he was actually telling us about how he is scared of infection because of this lack of protective gear. And that's what he was talking about in terms of not being able to speak up. Some cleaners get sick, within a few days of starting work, but many can go, for years without getting sick. And it was really interesting. There was like a passerby as we were talking. He was listening in on our conversation, and he started saying, cleaners only come for a few hours a day and then they leave, but patients have to stay in the hospital for several days at a time. And the cleaner interjected and said, well, we do the dirtiest of the dirty work and we come every day of the month. And, this cleaning work itself is quite dirty. And, just this passerby's comment just made it so clear that, these cleaners, their work is just not seen as important. And then that lack of importance sort of influences how risky people think the work is. So, I think if this work is seen as more important, and cleaners are sort of given more respect, more properly taken care of, it will sort of help both of these issues, these labor issues and the health risk issues.
Like I remember a signboard in a protest that I recently went in. It said, "More rights to others does not mean less rights to you." So here, in this situation of making a better delivery experience for mothers, and then also giving more rights to cleaners, they are not they are not contesting each other. And like if at all anything would come out of it, it would be beneficial for mothers who are delivering in the hospitals. They won't catch more infections. Like the NFHS shows us that more and more women are catching infections, and that would overall reduce morbidity and mortality, which is the goal of the government. And yeah.
Right, right. And what were the inequalities among cleaners? I mean, were there certain tasks that were assigned unequally based on gender and caste, especially since there are hierarchies even within large caste categories?
Many people told us that other castes are now doing this work. It's not just Dalits. But we did not find any cleaners who were non-Dalits. And I think even within that, there are some cleaners who won't do anything but jharu pocha. Like they're not going to go and clean the latrines. They're not going to go and be in the delivery room cleaning up the blood. And I think that is sort of breaks down by subcaste, who is actually kind of delegated to do that work.
And the other basis of delegation of work was the Pakka and Kacha employees. So Pakka employees would be those who are on the government roles, and Kacha are the contractual workers. Of course, contractual workers will have to work harder, and as Payal mentioned a little while ago, that they do that in the hope that they would one day become a Pakka employee like this other person in the hospital and get the same perks, and will not have to do the similar kind of hard work and filthy work.
Right. And the last question that I want to leave you both with is, what are the unanswered questions that you continue to investigate in your future work?
Yeah. A better understanding of how antibiotics are being used in maternity wards. We did, as Nikhil mentioned, try to follow the waste at the hospitals. Like, where is this bio waste going? And we found that the workers are working in pretty terrible conditions. And so sort of learning more about who they are, how is this work of handling bio waste done, and what does that mean for sort of infectiousness at a hospital and just more broadly. I think those are questions we definitely want to learn more about. But again, sort of more focused on these casteist notions and what they're really doing to health provision. I think that's kind of the deeper question.
That sounds quite interesting. I just want to thank you both for coming on the show, and we covered a lot of ground, and I think we went above and beyond the work that you published in EPW.
Thank you, Abhishek, for having us.
Thank you. Thank you for having us.
One thing that stuck out to me was the concept of task shifting, where cleaners would be made to do the work of Savarna doctors and nurses, but the work of cleaners would not be done by doctors and nurses. There were a lot more insights from the article that we didn't get to fully cover, and I do recommend reading the entire article published by EPW, and I've shared a link to it in the description of this podcast. Next week, we'll speak to Poonam Kathuria and Jagoda Rana about the role of the public healthcare system in addressing domestic violence based on their organization's work in villages in Gujarat's Patan district. Theirs is a unique initiative, and there's a lot for us to discuss. Do subscribe and tune in if the topic sounds interesting to you. Take care, and I'll see you in a week.